Hello, hi, good evening, everyone. Welcome you all for this webinar, Recent Advances in Hematology 2024. For the welcome and introduction note, I would like to invite program convener Dr. Ankur Mittal sir. Sir is consultant medic hematologist and bone marrow transplant, Mohan Oswal Hospital, Ludhiana. Over to you, sir, for further proceeding.
Good evening, everybody, and I welcome you all again today for the recent advances in the hematology 2024. So, as we have discussed yesterday, so we will be discussing a few new recent advances in updates in the myeloma, then followed by what's new in the Hodgkin's lymphoma, and then some newer updates on bone marrow transplant protocols and the treatment regimens. So, not taking much time, and we would like to continue the session. So, I request all my speakers and the chairpersons to be on time so that we can start the program on time and we'll finish on time. So, the first talk will be given by one of my close friend, Dr. Imran Khan. He's a consultant medical oncologist at Fortis Hospital, Amritsar. He'll be talking about updates in myeloma 2024. So over to you, Dr. Imran.
Hello. Yes. Thank you, Dr. Ankur, for providing this invite to me. It will be first of my to come into the hematology arena. Otherwise, we usually go for oncology side. And thank
Right.
you, Jensen, for providing me this for the slides and for this session, for sponsoring of the session. So next, so this is a disclaimer. So basically, multiple myeloma, as all we know, there is an excessive proliferation of the plasma cells, and because of those, there is excessive increase of the abnormal immunoglobulins, and there are a plethora of cytokines that release, and ultimately it leads to anemia, bone pains, hypercalcemia, infections, renal insufficiency, and this progression ultimately leads to progression of the disease. So next slide. This is the spectrum, or the what we call in normal terms the journey of plasma cell dyscrasia that starts with MGUS, then smoldering myeloma, and ultimately into active symptomatic myeloma. So in GL, as all we have to know, the crab features were there, and later the slim has been added. So simply calcium, crab stands for calcium of a level of greater than 1 mg per upper limit of normal, renal insufficiency greater than 2 or less than 40, of GFR, anemia of less than 10 grams per deciliter or 2 grams or less than of upper level, and bone disease greater than 1 of lytic lesion, and slim as for 60, and I for serum free light chain ratio greater than 100, and MRI if there is 1 or greater than 1 focal lesion, and the cutoff that they have given is a 5 mm. So anyone that fits into this criteria, a plasma cell dyscrasia, plasma cells of 10%, one of these, or slim, any of one factor that qualifies for myeloma. Next. This is the basic performance that we all follow for the patient on a diagnosis. And besides these parameters, we what is the latest is that we now add the minimal residual disease, sometimes at the beginning and at the end, but at the end of the treatment, that is the latest in vogue that we'll discuss later on. Next, next, next. Next slide. So these are the standard risk factors that we usually follow as per the cytogenetic factors. The high risk factors, they all revolve around the chromosome 14. So 4, 14, 14, 16, 14, 20 are all notorious, and deletion around 17p, P53, and gain and loss of 1q. And there are other RISS stage 3 high plasma cell phase and some high risk signatures that usually we get in NGS. These have been termed as high risk, and the rest, like trisomy 11, 14, 6, 14, they have been considered, including trisomy as standard risk. Next slide. So this is the basic and one of the beautiful this diagram to show the profile of the myeloma, with the journey that starts with the asymptomatic as megas of smoldering multiple myeloma, ultimately with time progresses to active myeloma. Then we give treatment. There are periods of remissions, and there are periods of relapses. And ultimately multiple these new kind of drugs that we are seeing as of now, like relapse after third line, fourth line, these patients, even after transplant. So this is what is normal. So what has been rightly termed multiple myeloma is a marathon. It's a big disease that the patient, it usually remains for a long time with us. So treatment goes on, goes off, and so is that because of the disease profile. Next slide. So this is the basic current treatment paradigm of multiple myeloma. we usually see the patient whether the patient is transplant candidate or not. If he's a candidate, we go for induction or primary therapy with the protocols, usually a triplet that we'll discuss further. Then after the remission, we go for transplant, and we require a consolidation therapy for 1 or 2 cycles, and followed maintenance therapy that usually follows for 2 years. And for non-transplant candidate, we give induction therapy that goes for around 1 year, and followed by maintenance therapy. Although with this usual protocol, there are some changes of the cycles. So what is the basic idea? Basic idea of giving induction chemotherapy or primary therapy is to use 3 drugs that are a triplet, because it helps in aim for the deepest response, and it helps in the conversion of patient into stem cell transplant. And this, whether the patient has been already told, whether the patient transplant eligible or ineligible, it depends on so many factors, including age, organ function, and other risk factors, whether the patient is able to bear high dose chemotherapy. So triplet chemotherapy, the advantage being a better response rate, a better PFS and OS, and a deeper remission of the disease, and uses of multiple drugs with different mechanism of action that provide effective control of the drugs and prevention of drug resistance. And the latest is the addition of immunotherapies, is the monoclonal antibody like anti-CD38 that have added one more spectrum of, or they, what we can tell, like they have added one more, the treatment options are opened up because of these immunotherapies. And in further lines of immunotherapies, including CAR T cell therapy that we'll discuss later on, they also like give us multiple options. Next. Oh, this is the normal do relapses. So we can see, depending on the different permutations, combination, we can use a drug that has been already used. We switch that with some other form of drugs, and usually we find these patients at third or fourth, and we have patients that keep on following. And ultimately, the disease develop refractory, while we have to give some drug that is available as per the region, as per the availability, as per the logistics. Next. Hello. Yeah. So these are some of the drugs that have been the timeline of, like, initially in 2000s, we got a drug by IMiDs for rotosomib, then doxorubicin was found later on, IMiDs include lenalidomide, then pomalidomide, and the journey kept on increasing. Next. So these are some of the broad classification of drugs that are used in multimodal. As all of you know, the IMiDs class, we need to have thalidomide, lenalidomide, and the pomalidomide. In proteasome inhibitor, we have the bortezomib, carfilzomib, and ixazomib. In steroids, we give dexamethasone or sometimes prednisolone. In monoclonal antibodies, anti-CD30, we have the daratumab, isatuximab, and olatuzumab. Where chemo drugs include cyclophosphamide, bendamustine, melphalan. And then we have these drugs that, as of now, we don't use much, like XPO1 inhibitor, selinexor, panabinostat. And besides these drugs, we require some bone supporting drugs, supporting care medications, including bone modifying drugs, prophylactic against infections, and sometimes because bone is an issue, so pain care and prevention of DVTs and fracture stabilizing and others. Next. Next slide. So when you give the triplet drug, so a scenario comes when the patient develops a refractoriness. Usually the upper two, Len refractory and border refractory, are the most common. And we switch this simply, we try to switch this drug with some other drugs. And especially what my personal favorite, or what we have seen common with daratumab based, or then like they have provided us with more response. So dara, we switch the Len with something else, like Dara with Botsovitexa or Dara Pomaladexa. And in subsequent lines, we have like Len and Botsovit refractory. Then we see which drugs have not been used, and we try to introduce those drugs to provide a longer remission. Next. So, line about the Dara, it is one of its kind is anti-CD38. It binds the molecule and helps in myeloma cells by different, which are basically immune therapy mediated, cytodependent, and it has provided a definite role in multiple myeloma, especially in first line, in all form like transplant eligible, transplant ineligible, in first line as second lines, as well as combination with all the different kinds of classes of multiple myeloma. Next, next, next. So going back to the basics that we have discussed, like we have the with the patient. If the patient has not any MDEs, myeloma defining events, the crab slip is not there, then the patient is either, depending upon the criteria, he can be kept on follow with the patient mucus, or if the patient has smoldering myeloma, high risk, 20% plasma cells, 2 gram of Mg, and all those risk factors, then we can give them doublet drugs. Otherwise, if patient follows any of the criteria of symptomatic myeloma, we follow him as treatment and we treat him as active myeloma. The standing treatment protocol is same as it is. Next. So if a newly diagnosed as the patient is transplant eligible, then as per standard risk or high risk, for standard risk, we usually give a triplet, or sometimes we can add to a DARA VRD, depending upon so many factors, including the age of the patient, including the logistics, including the expectation of the patient. And after that, after remission, we go for early autologous stem cell transplant, or in certain cases, if the transplant is not there, patient is young, we go for stem cell collection, give them more of the drugs, and subsequently we can go for delayed autologous stem cell transplant that we can keep for at a relapse. And in case of high risk, we give triplet drugs for 4 times drug. Previous slide. We give the 4 drug regimen followed by transplant, and then maintenance here is different. As we know, we give doublet as maintenance, Watson line maintenance for 2 years. Next slide. Next. Next slide. Okay. So for transplant ineligible, we give VRD or DARA-RD. Both are equally good, and followed by maintenance of line. And in DARA-RD, we have to continue this until progression. In high risk, again, we have actually both. There's not much of a difference. Only difference in the maintenance. In high risk, we have to continue with doublet boards of line maintenance. And in certain circumstances, for example, line is not available, or patient is having creatinine, high creatinine, we can avoid line and give VTD or any other formulation like Cybody or even DARA VTD. In ARF, again, the same situation. And if patient is having a high tumor burden, like if a patient is now the cells are in the blood 5% more, then he qualifies for plasma cell leukemia, where we have to try for chemotherapy. Next. So at first relapse, again, as has been discussed, depending upon which drug has the patient has been exposed. Usually, the patient is usually exposed to the LEN or to the borzomin. Then we have to use the other form of treatment. So if a patient is refractory to LEN, we give other form of like borzomin based, including daratumab. And if a patient is refractory to borzomin, we usually use lenalidomide or subsequent lines of drugs, including carfilzomib, pomalidomide, and all that. Next. And for further relapse, like fourth line and all, this is the NIVER and the brighter future of myeloma. We use these are the NIVER form of drugs like anti-BCMA strategy. We have the bispecific antigens, we have the CAR T cell therapy, and we have the latest antibody drug conjugate by the name of belantamab modified. And there are certain drugs like selinexor, elotuzumab that are being used, but we have not, as a I don't have experience using these drugs. Next. So the basic updates that we go rushing through the slides. So first and foremost is the minimal residual disease. So the test that has been recommended is the NGS. NGS is the preferred test for detection of MRD. Although in some this flow cytometry has been used in certain services, but NGS is the sine qua non is the basic test for commercial MRD. So value of 10 raised to -5 should be there for diagnosis or depth of the response. Next slide. So these are the various pooled analysis in which it has been shown that of achieving a greater MRD has been shown it translates into a better form of treatment modality. The dark blue these bars are of MRD negative, and those of light blue are the MRD positive. So in all forms of treatment, like transplant eligible, newly diagnosed multiple myeloma, transplant ineligible, newly diagnosed multiple myeloma, in a relapse setting, and in pool, and in everywhere you can see the MRD negative group has provided better form of treatment. Next slide. Open one करिए बस. So next slide. Next slide. Okay. If the patient's MRD negative, then the patient will feel like the patient can be connected, and we can expect that the patient has a greater depth of response. So now, again, this updated analysis of MAIA study, the basic design. Yes, next. Next. The basic design of the study was the key eligibility criteria were transplant ineligible, newly diagnosed multiple myeloma with PS of 0 to 2 and a creatinine clearance of greater than 30. So in the study arm was the DARA RD, and in control arm we use the RD group. Next. So this is the age characteristics which we will discuss on further slide also, that were very well balanced. Even they had used, there's a subgroup of greater than 75 years or 160, but we will discuss about that in later slides. Next. And this is important, like in update analysis, in which they have taken a follow-up of 64.5 months and OS of follow-up of the tune of 73.6 months. They have seen that the patients who have discontinued treatment, the DARA RD, it is 64%, and in RD it is 85.2%. So the figures tell by themselves that DARA RD is a very good regimen for patients who are transplant ineligible in newly diagnosed patient. Next slide. And looking at this PFS curve of Kaplan-Meier, you can see that there's basically very early separation of the graph, and it is showing that the PFS even in DARA RD, if the patient is not like, the main problem with DARA is the acute hypersensitivity reactions. Otherwise, the leukopenia, etc., they are mostly manageable, and you can have a better PFS in transplant ineligible patients. And depending on this long-term follow-up, this is a very good regimen to follow. Next. In the OS, you can see the OS in the study arm, it has not, so again, very like showing data that DARA RD is very good regimen for transplant ineligible candidates. Next. 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 So looking at the subgroup analysis of this MAIA study. Next. So you can see that if we have divided the age group into three groups: less than 70 to 75, less than 75, less than 70, 70 to 75, and greater than 75. Next slide. Next slide, please. Yes. So in this graph, it has been clearly seen. Previous slide. In this graph, you can see in the left-hand side, the graph, this the age, even in all age groups, less than 70, 70 to 74, greater than 70. As per the age group, the lesser the age group, it has fared well as compared to the older age group. And even in terms of PFS. Next slide. Next slide, please. So has even in this age group of greater 75, that I want to emphasize that even in this group, the response rate of the DARA RD regimen has shown a very good response, and the hazard ratio is I think it is 0.59. So it's again a very good regimen in very elderly transplant ineligible patients. Rather than giving a doublet, we can give them a triplet with DARA RD, and the results have been there, because this is the overall, the side effects are manageable. Next slide, please. Next slide, please. Okay, looking at this, next slide, please. So again, looking at the high risk factors in this study population. Next slide. So this is the forest plot curve, in which if we look at these variables like age greater than 75, ISS stage 3,
Imran sir, sorry to interrupt. Kindly conclude, please.
Yes, I'm coming. And even high risk on all these features, DARA RD has favored in a better way. Next. Hello. Hello. Yes, yes. Next. Next, please. Next. Yes, yes. So this is a small in which they what they have tried for the re-emphasizing the MIA trial and the SWOG 70 this SWOG trial the 7S0777 in which they have pooled up these two groups and included the transplant ineligible candidates. Next slide. Next slide. Yes, yes. Keep it, keep it, keep it. So they've done an indirect comparison in which they're again compared here Dara RD versus RT. It has been seen that the response has been very much. If you can see that in SWOG 007, in which there was a pool of both transplant eligible and ineligible. Candidate was 12%, but in pooled analysis of taking the ineligible only patients, transplant ineligible, the response had been of the tune of 40%. So it is this is this is comparable with the MAI trial. Next slide, please. Next slide. Next, yes. So this is my last slide, previous slide. So what I have told, like these are the basics of the myeloma, but the myeloma treatment is very promising. Actually, the new future of the multiple myeloma is what is this NCCN slide, in which we have to use CAR T cell therapy, bispecific antibodies, and the latest is this belantamab mafodotin, in which their trials are ongoing, where they have been using either in the actually as of now these are used or indicating fourth line, and probably in India it is yet to come, but the trials are ongoing in first line, in second line, and third line. Maybe in future we may have multiple treatment options and multiple responses, and maybe there's a bit of confusion, and maybe there's a bit of excitement also that which treatment we have to choose later on. As of now, the triplets they stand the standard of care, and DARA should be included in all forms of treatment, especially in high risk cytogenetic abnormalities. Thank you.
Thank you, Dr. Imran. I know it's just 15 minutes and to discuss multiple myeloma, the means we can have a session over it. But it's
Thank you
really
for having me.
and you have discussed DARA as the response rates are very good with using DARA as first line or with the quadruple or triplet therapy. So we are already running late, so we jump to the next session. The next session is on polatuzumab. So we all are talking on DLBCL. The R-CHOP is the gold standard, but now we have the pola in previously untreated DLBCL. This topic will be taken by Dr. Mukesh Chawla. He's a consultant and a bone marrow transplant physician at Swan Hospital, Mohali. Welcome, Dr. Mukesh. And
thank you, Dr. Ankur. Thank you for such creating this forum where we can discuss all these things. So, shall we proceed further?
Yeah, we can.
So, someone will be sharing, or shall I share? I think let me share. Is the slides visible? Is the
Yes, sir.
slides visible?
Yes, sir.
Yes, sir.
It is.
So again, it is going off. Yeah. Can you all see?
Yes, we can.
Yeah. So today we'll be discussing this newer therapy, which is in a MAB, which is polatuzumab vedotin in previously untreated DLBCL. So this session is the slides are shared by the Roche. So we'll be discussing this is the latest therapy in the DLBCL, which is a great lacuna. So DLBCL, as we know, is the commonest non-Hodgkin lymphoma. So as we know, lymphomas constitute Hodgkin and non-Hodgkin. So around 30% are Hodgkin, 70% are non-Hodgkin. Non-Hodgkins constitute B cell around 85%, and T cells and NK constitute 15%. So among the B cells come the most common DLBCL around 42%, then follicular, SLL, and the TK and NK cells most common are PTCL, ALCL, and extranodal NK T cell lymphomas. So every year in India we have around 25,000 new cases of DLBCL. So coming to this this treatment journey, as we know that the first line therapy, we know that it is a standard R-CHOP regimen, and around 60% of all receive the first-line DL therapy with R-CHOP. But around 40% do not respond to this, either have a failure or progression, and only select of these patients receive the second-line therapy. So around 20% with the second-line therapies like auto transplant and CAR T cell therapies, around 20% receive this projected cure with CAR T cell therapy, and only 5 to 10% with the auto transplant. So among them also around 35% patient progress with the first line therapy and receive subsequent therapies. So again, after the second line of therapy, around 25% respond to the therapy and again have a like similar life expectancy as that of a normal age group. But otherwise, around 75% again do not respond or have a progression and go for the subsequent therapies. So this was the standard of care since decades. So first, the CHOP was there started in 1976, and again till 2 decades there was no MAB or immunotherapy when this rituximab came as a first targeted treatment for the B cell non-Hodgkin lymphoma in 97. And by 2002, it became a standard of care with the R-CHOP in the DLBCL. So what after next, from the last 2 decades, we have only R-CHOP as a standard of care with no significant improvement in your progression-free survival or overall survival after this. So we know that it responds only in 60-70% of patients. So what about our rest of the 30 to 40% of the patients? So as you can see, the R-CHOP changed the treatment landscape in DLBCL. So these were the two arms, arm A and arm B. So it was R-CHOP versus CHOP. And as you can, the survival distribution function was better in the patients who received R-CHOP, with a significant improvement in overall survival by around 13%. So R-CHOP does not cure many DLBCL groups, as we know that. So we know that it is a heterogeneous group with the huge variability among this subgroup analysis if we do. So as we know that we have IPI scoring also. So we see that a lot of patients get cured only in these subgroups where the IPI score is low, and if it is early stage 1 and 2, and if it is a GCB where we divide DLBCL by cell of origin. However, there is a low curability in case of high IPI, high age group, non-GCB phenotype, especially ABC subtype, and when there is a dual expression of markers like MYC, BLC2 rearrangement. So for patients not cured by first-line treatment, for prognosis worsen throughout the patient. So as you can see, so around 60 to 70% of patients can be cured by the first-line R-CHOP therapy. And screening and diagnosis median overall survival is around 15.8 months if left untreated. First-line R-CHOP 2-year survival is overall around 88.6%, with around 70% of progression-free survival. So as we know, around 30 to 40% of patients relapse refractory after receiving the first-line R-CHOP therapy, and second line with the multi-agent induction therapy, CAR T or auto transplant, with or without transplant or in combination, the median overall survival is roughly around 12.5 to 33.5 median months. And median progression-free survival is around 8.3 to 11.6. And despite that, around 75% of patients relapse and progress when they go for a third-line treatment and beyond, where there is no standard of care therapy in the third line. And median overall survival at this is 7.7 months. So various studies have been attempted to optimize the R-CHOP in the past, like enhancing, first was with the replacement of rituximab with Gazyva, with the newer anti-CD20 therapy, and addition of targeted therapies in like robust, remote trial, Phoenix, Maine, where there was addition of lenalidomide, bortezomib, ibrutinib, and bevacizumab, and addition of further chemotherapies like gemcitabine with R-CHOP, diapoc against R-CHOP, or shorter duration of R-CHOP like R-CHOP 21 versus R-CHOP 14. So all these studies failed to improvise on the progression-free survival or overall survival as compared to R-CHOP. Even with the maintenance therapy was tried in this DLBCL in different studies, where different maintenance therapies was tried like rituximab, everolimus, and enzastaurin. However, it failed to achieve the primary endpoint in the form of increased progression-free survival or overall survival. So should cell of origin be used to inform treatment decisions? So different studies have been done, like this Robust2, Phoenix, Remodel, and ECOG-ACRIN, where different agents were added to R-CHOP regimen. Like in ECOG-ACRIN, lenalidomide was added, and subgroup analysis by cell of origin was done. How there was no significant difference between There was little bit of overall improvement in progression-free survival with the addition of len. However, there was no significant difference in the ABC subgroup. In the robust 2, again lenalidomide was added, and it was there was a favoring trend in the high risk patients. However, it doesn't meet the primary endpoint of increased progression-free survival. And again in Phoenix 3, ibrutinib was added. Again, no significant improvement in event-free survival or in the ABC subcategory. And the remodel study was addition of bortezomib. Again, there was no improvement in progression-free survival in a different cell of a region, DLBCLs. So again, so in the treatment landscape, now has come this newer map, which is polatuzumab vedotin. So after 2 decades, we have got a new immunotherapy. Let's see what the data says. So polatuzumab vedotin, it is an ADC conjugate. So it's a map which is an antibody drug conjugate which targets a CD17 by 79B. So these, as you can see, 79B receptors are there on the cancer cells, and this ADC binds this. CD79B is a signaling component on the B cell antigen receptor complex that is ubiquitously present on the all DLBCL cells. And this polatuzumab consists of a potent microtubule inhibitor MMAE, which conjugates to CD79B monoclonal antibody via protease cleavable peptide linker. So as this ADC binds to the CD79 receptor, it gets internalized where this cytotoxic agent is released in the lysosomes. And as we know that it is a potent microtubule inhibitor, it causes a microtubule disruption. As a result, it causes a cell death of the apoptosis of the cancer cells. So now coming to the POLARIX trial, it is a global randomized double-blind placebo-controlled trial. It was published in NEGM, and study was done by Tilly et al. So this was studied in previously untreated in the DLBCL as a first line. So this is polatuzumab vedotin. What was there instead of this R-CHOP, they replaced vincristine by the polatuzumab. So there were 6 cycles every 21 days. So polatuzumab was used in place of vincristine. So POLARIX was a phase 3 evaluating trial which evaluated Pola R-CHP versus R-CHOP. So as the results from the polatuzumab was very good in the lab setting, so it was tried in the upfront setting also in untreated DLBCL patients, where the standard this oncovin was vincristine was replaced with the polatuzumab. So there were around 879 patients were there in the age group of 18 to 80 years. IPI was higher, 2 to 5. ECOG was 0 to 2. Randomized as 1:1 in the 2 groups with RCHP with vincristine placebo, 6 cycles, 21 days versus R-CHOP with polatuzumab placebo. And then there was a maintenance of rituximab in the 7 and 8 cycle. Stratification factors were IPI score, bulky disease, and geographic region as well. So bulky disease are more than 7.5 centimeter. Primary endpoint was progression-free survival, and secondary endpoints were also studies like event-free survival, PET-CT complete remission at end of treatment, and overall survival and safety. So this was the data of the 2 subsets in the 2 groups. They were almost comparable in terms of ASX and performance status. Bulky disease also more than 7.5 centimeter. They were almost comparable, 44%. Elevated LDH and Marburg staging, extranodal site, IPI scoring. So mostly it was higher IPI scoring. 3 to 5 was around 62% in both the groups, and 38% was lower IPI score. And depending upon cell of origin, so mainly it was GCP subtype, again comparable in the around 50 and 56%, and ABC subtype was 35 and 31%. And then the double expression also almost they were comparable, around 40%, and triple was around 6 and 8%. So this as per this study, I think these graphs are missing from here. So okay, we'll go ahead. So POLA R-CHP demonstrated a 27% reduction in the relative risk of disease progression, relapse or death versus R-CHOP, and around 24-month progression-free survival, around 76.7% with the POLA R-CHP versus 70.2% with the R-CHOP. So you can't see the graphs here, but as you can see, there was around the progression-free survival was 24-month progression-free survival was better with the Pola group than the R-CHOP group by around 6.5%. And there was a hazard ratio was around 0.73. So there was a 27% reduction in the relative risk of disease progression, lapse, or death. So this was with the additional follow-up, as you can see. So these are the progression-free survival. A little unclear, but as you can see, the up one is Pola RCHB and the lower one is R-CHOP. So as you can see, there is a significant difference in the progression-free survival in the two groups with the better PFS in the Pola group. And with the extended follow-up from 24 to 36 months, again, it was a almost additional progression-free survival was better with around 7.7%, which was 6.5% by 24 months, which increased to 7.7% by the 36 months. So as you can see, PFS benefit with the Pola group was versus R-CHOP was maintained with longer follow-up with a hazard ratio of 0.76. So 24% reduction at median 3-year follow-up also. So effect of achievement on progression-free survival 24 on efficacy on the longer follow-up. However, there was the progression-free survival gradually reduced with the almost comparable in the two groups. However, there was no difference in the overall survival in the two groups. So 18 months after progression-free survival 24, in the both the groups around 90.3 and 88.7% respectively were there in the progression-free. And overall survival rates were 98.3 and 98.9 with the Pola and the R-CHOP respectively. So as you can see, with the longer follow-up, there was a the progression-free survival gradually decreased with the no benefit in overall survival in the both arms. So as you can see, with the addition of Pola upfront, there was a significant improvement in progression-free survival with the relative reduction in death rate. However, there was no improvement in overall survival. So coming to treatment effect on primary refractory disease. So as you can see, cumulative incidence of primary refractory disease in the first line therapy, it was significantly reduced in the Pola group as compared to the R-CHOP. So cumulative incidence of refractory disease was around 22.7 in the Pola group compared to 29.7 in the R-CHOP group, with a significant p-value. As you can see, the blue line is R-CHOP. The primary refractory disease was comparatively lower in the Pola group. So this was subgroup analysis. As you can say, the progression-free, they have done a subgroup analysis. If you see, in the more than 60 years, it was better in the Pola group, and by gender determination, it was better in the male group in the Pola group. And ECOG performance, IPI scoring by 3 to 5, it was better in the Pola group. Bulky disease, however, if it was absent, it was better in the Pola group rather than a bulky disease. So almost comparable results by geographic distribution. However, by N-Arbor staging, the lower the stage, the results are better in the Pola group, as you can see. However, it was still significantly better in the Pola group. And depending on baseline LDH, any value, it was better in Pola group. Depending upon extranodal sites, better in Pola group. Depending upon cell of origin, it was better in the ABC group subtype, as you can see. So it was almost comparable in the GCB subtype. However, it was better in the ABC subgroup. And depending upon double expression, the more the expression of this MIC and this, it was better in the Pola group. And depending upon double and triple hit, the responses were better. Better if the in the Pola group, if the absence of these markers were there. So this is investigator assess progression-free survival by the cell of origin subgroup analysis. As you can see, as we discussed up also, the 2-year progression-free survival was better in the ABC subtype in the Pola group versus the R-CHOP. So in the Pola group, it was around 85% progression, 2-year progression-free survival versus 56% with the hazard ratio of 0.34. So around 66% reduction, relative reduction in the progression in the ABC subtype. However, it was comparable in the GCB subtype. So there was no significant improvement in progression-free survival in the GCB subtype in the Pola group as compared to the R-CHOP. And in unclassified, as we know that there is a little difficulty in classifying also by various criteria. So there were some subgroups where it was unclassified. There also you could see that there were progression-free survival was better in the Pola, it was actually where it was unclassified that it was better in the R-CHOP group. So if you divide it subgroup analysis depending on cell of origin, we could actually see the Pola group actually worked better in the ABC subtype with a significant improvement in progression-free survival as compared to GCB subtype. So compared to elderly subgroup, as you can see, it was the responsive 2-year survival was better in the elderly group in case of Pola by 77% as compared to 67% in R-CHOP. Higher overall survival was comparable in the two groups with 86% versus 83% in the R-CHOP. So risk of progression, relapse or death was lower with Pola R-CHP versus R-CHOP. And OS data were immature but showed trends for reduction in the risk of death with the Pola group. So as you can see, little better in the Pola group, but however the values were not very significant. So this is the Asian subset. As you can see, the graphs are not very clear. So as you can see, the progression-free survival was better in the Asian subset also. So the results were correlated with the Asian subset also in terms of progression-free survival. However, there was no significant improvement in overall survival. So there was a clinical meaningful improvement in progression-free survival in the Asian population also, with the risk of disease progression, relapse or death was reduced by around 36% with Pola group as compared to R-CHOP. However, overall survival demonstrated a trend, but it was not significant as the study was not very prolonged. However, it showed a trend for reduced risk of death with Pola as compared to R-CHOP. So coming to EFS, event-free survival efficacy, the Pola RCHP versus R-CHOP hazard ratio was around 0.75 with a significant p-value. As you can see, it was consistent with the primary endpoint progression-free survival, and most of the events were due to the disease progression. So it almost correlated with the progression-free survival. So again, sub-analysis by the PET-CT complete remission at the end of treatment. So again, at the end of treatment, assessment complete remission was achieved around in 78% in Pola subgroup compared to 74% in R-CHOP. So in patients with complete, the disease-free survival was longer in patients who received Pola as compared to the R-CHOP. So overall survival analysis, however, there the two groups were, so median follow-up was around 39.7 months. So the two groups were almost comparable in terms of overall survival. So there was a definitely improvement in progression-free survival, event-free survival, and complete remission with this Pola subgroup. However, there was no significant improvement in overall survival. So hazard ratio was around 0.73, but it was in the ratio was 0.94. So it was not a significant p-value. So there was no difference in the overall survival in the two groups. So patients in Pola arm required, however, in terms of subsequent lymphoma therapies, as you can see. So there was in the Pola group, they required less subsequent lymphoma therapies. As you can see, any treatment, it was around 22 compared to 30%. Radiotherapy around 9.3 versus 13%. Any systemic therapy 17% versus 23.5%. Stem cell 4% versus 7%. CAR-T 2% versus 3.6%. So risk of requiring second line therapy after Pola and Polarix. So patients receiving 34% less likely to require second line therapy than those receiving R-CHOP in patients who receiving Pola upfront. So this was the safety profile of the Pola. Lot of side effects were like common what we see. So mainly it was peripheral neuropathy, which is same as vincristine. So that's why it was replaced with vincristine upfront. Others are nausea, diarrhea, hematotoxicity, constipation, decreased appetite, febrile neutropenia, cough, headache. So these were however, there was no significant difference in rate or severity of peripheral neuropathy or other side effects in both the arms. So these are the advertisements. As you can see, in terms of peripheral neuropathy, nausea, hematotoxicity, diarrhea, or anemia, they were almost comparable in the two groups. So coming to the NCCN guidelines of DLBCL now. So in the low risk stage 1 and 2, where they have excluded extensive mesenteric disease. So upfront is still R-CHOP. However, in the extensive disease stage 3 or 4, or with extensive mesenteric disease in stage 1 or 2. So they have advised preferred regime is R-CHOP, which is category 1. However, Pola R-CHP is recommended again category 1 for a higher risk disease stage 3, 4 or extensive disease. Other recommended regimens are Diapoc or other regimes along with the rituximab. And in patients with poor left ventricular function, all stages, the various recommended regimes are, in addition to all this, are DIPOC, RC-DOP, RC-OP, what we can see. And in very frail patients, you don't give R-CHOP, you modify to little less intensive regimes. So coming to impact of PolarX, as you can see, so this is a newer therapy which has come into play after 2 decades, which has shown a significant improvement of progression-free survival from the R-CHOP by around 6.5%, as you can see with the relative reduction in hazard risk. However, there is no improvement in overall survivor. However, it is a very good therapy. What I recommend could be in the elderly age group and the in extensive disease like stage 3, 4, and in like frail patients or elderly age group. So that's for discussion on polatuzumab. So that is best what we can do for our patients as for now, but we need more data where we can have use of this drug and discuss about this thing. Thank you so much. Back to you, Dr. Ankur.
Thank you, Dr. Mukesh, for the wonderful presentation. And Dr. Mukesh, one thing: are you giving Pola as first line, or are you giving the options to the patients?
Dr. Ankur is just launched, so we have no experience till now. I have not used it, but yes, upfront still we are not using. Definitely as a second line, definitely. But yes, with the option coming as this is a some subset for patients where we see that, like in elderly patient with extensive disease or higher stage, or where you see a ABC subtype, where you can't be or where you won't be able to use R-CHOP. So keeping aside the cost issue, we can recommend patients about uses of polatuzumab upfront also, where
Right.
we know that the disease progression will be very fast.
We have means one of my family friend has taken Pola as second line, but unsuccessfully they have taken just first dose, and they were not willing to proceed further because the disease was aggressive, and we lost him. Uh, let's see how these drugs do. Means currently we are giving Pola, means we I'm at least giving the option to the patients. Yes, this drug is available, but we have not, means even I have not used anywhere as first line till date.
Dr. Ankur, we need to see that our patients are very frail. Even beyond 60 years, you see a lot of cytotoxicity with our this current regimes. So with the little bit convincing data we have, like not improvement in all survivor, but definitely at in the old age group, the progression free survival matters more than overall survival, what I feel. And with the significant improvement in this, whether it is very little, and with the significant reduction in the risk of death or further progression, so giving an option to these kind of patients where we know that they have a high risk of progression, like in ABC subtype, so I think we should be opting for, and we have to reduce the side effects also, which most of our CHOP patients don't tolerate still in
Yeah.
the elderly age group. So we need to, I think, offer all this therapies to our patient.
You know anything like is this can be used for double hit or triple hit? Means I don't know. Means one of recently we have seen one patient's triple hit. Even I need to check the data. Is the Pola data is there with the triple hit DLBCL or double?
So they have this few subset analysis in the double it and triple it also. But again, this testing is still not very rampant in our setting. And once we know that it is a double it and triple it, so we are not able to escalate beyond R-CHOP, where we need to actually escalate. So for our these kind of subset ratio patients, so they are kind of DLBCL subgroups only, though their WHO has classified it as separately. But they are so they have in this PolarX trial where they have given PolarX to polatuzumab to these patients, but it was very limited to say that that significant effect was there or no.
Thank you, Dr. Mukesh. DLBCL is something which is everlasting, and we keep on discussing, and we keep on having new and new cases and new things in mind.
Yeah, right. With so much varied presentation, but at least we have something beyond our job now to discuss.
Yeah, true, true.
Right.
So, not so as we are on time, so we are going to the next topic. So the next topic is conditioning regimen in BMT. So this topic will be taken by Dr. Meet Kumar sir. He's a director and HOD hemato-oncology and a bone marrow transplant at Maringo Asia Hospital, Faridabad.
Thank you, Dr. Ankur, so much, and congratulations for organizing this wonderful meeting, I would say. Can
Thank
I have the
you.
slide projection from the organizers' end?
Yeah, sir.
Okay. So what I'll do is I'll just walk you through in the next 10 minutes about what are the conditioning regimens that are available for the different types of bone marrow transplant, autologous, allogeneic for different indication by indication. Next slide, please. So I'll be covering about a brief overview of how do we define the conditioning regimens, and then thereby sort of how do we classify these conditioning regimens and what are the benefits and disadvantages of these different conditioning regimens based on the classification, and finally about the disease-based sort of understanding of these conditioning regimens. Next slide, please. So yeah, so what does conditioning mean? Conditioning means to prepare a patient for a bone marrow transplant, and this is one of the most crucial steps of a bone marrow transplant, because once we have fired sort of the regimen or the medicines or the chemotherapy that we intend to do, and after that nothing remains in the clinician's hand. So this is the first step that is taken towards establishing like taking a patient for a transplant. That means it has a repercussions even after 3 months. So if you are going to give a MAC regimen, myeloablative regimen, that means that the patient is going to experience bad mucositis, and that is a precursor to GVHD, and that can ultimately have a TRM. So if you are going to use a less intensive regimen like RIC regimen or a non-myeloablative regimen, that means it will have an impact, although it will have some beneficial effect in terms of lower TRM, but it will have a more chance of sort of relapse because the disease has not been addressed optimally. So these are the times that a most important clinical discussion and clinical sort of decision making takes place while taking a patient for a transplant. Not only the disease condition, but the general condition of the patient, the comorbidities, and other logistic things do come into play, because like we keep talking about TBI for an ALL patient who is undergoing a transplant, but we know that that's a limitation. Most of the centers, or I should say 60% or 70% of the centers, do not have a TBI facility. So yes, there are limitations, there are factors that needs to be considered before coming to a final conclusion that yes, this is the conditioning regimen that we are going to use for a particular patient with a particular disease. Next slide, please. So the goals for the conditioning regimen includes like first goal, of course, is disease eradication. That means whatever disease remaining in the bone marrow after whatever conditioning regimen has been, whatever the chemotherapy has been given, that has to be sort of given to clear the disease. If it is a benign disease like thalassemia, sickle cell, those sort of abnormal clonal red blood cells or erythroblast needs to be cleared before the patient is taken up for a transplant with a donor going inside, donor stem cells going inside and start to produce the normal marrow. The other purpose is immunosuppression. That means the immune component of the bone marrow, the lymphoid component of the bone marrow also needs to be ablated. That is achieved with a combination of myeloablation and immunosuppression. Next slide, please. Yeah, so this is about the immunosuppression. Next slide, please. And of course, the other step that is a bit of controversial statement, that whether creation of space is required for a bone marrow transplant purpose or not. But yes, this is a statement that has been usually considered as an objective for a conditioning regimen that needs to be achieved. So next slide, please. I'll just skip in the interest of time. I think we have 10-12 minutes. So in the interest of time, what I'll do is I'll skip the historical aspect of how the conditioning regimens were developed. And may I request directly to go to the conditioning regimen? I think it's around slide 20 or 21. 21? Yeah, this one. So yeah, so what is conditioning regimen? Like what are the types, what are the definitions, and what are the advantages and disadvantages? Next slide, please. So what is important is about the timing of transplant. We all know that we are all transplant physicians sitting here, and we know that the conditioning regimen, once it is given, after that there is a stem cell infusion, and after that whole lot of sort of complications related to transplant can happen as late as up to a year or 2 years after the transplant. Initial phases are like sort of more importantly marked by common occurrence of infections, bacterial because of neutropenia, or maybe candida, and maybe at a later time point other fungal and viral infections, including CMV, EBV, HHV6, and other viral infections. And of course, at some point of time after the engraftment, there is more a common occurrence of GVHD, graft rejection, and of course, still later, acute, like after the sort of acute GVHD phase is over, there is a chance of chronic GVHD that can occur as late as 2 years after the transplant. Next slide, please. So these are the types of conditioning regimens that are the preparative regimens for transplant: myeloablative, non-myeloablative, reduced intensity conditioning. Next slide, please. So what is interesting to understand and learn here is, as we are advancing into the ages, as like we are year on year, there is more and more sort of reliability and acceptance of RIC conditioning regimen as compared to myeloablative or non-myeloablative, as like simply because of the reasons that we are just going to discuss, and like we already discussed briefly a while ago. So RIC regimens are increasingly being incorporated in all clinical sort of conditions where a bone marrow transplant is indicated. So we'll be discussing about these regimens in the subsequent slides. Next slide. Next slide. Next slide. Yes. So this is what is the myeloablative conditioning regimen. Different groups have defined these regimens differently. How does American Society define it? A myeloablative conditioning regimen is as those conditioning regimens or those combination of drugs and molecules that are going to produce a profound cytopenia and myeloablation that is going to last till the stem cell infusion is done. So that means if the stem cell infusion is not done for a patient who has received a myeloablation, this patient will never recover from its bone marrow. That means he will have a permanent sort of a cytopenia and bone marrow aplasia that is never going to recover unless and until it is rescued by a stem cell infusion. So that is something called as sort of a myeloablative conditioning regimen. How do we define it? In the next slide, please. So these are the definitions how we define a conditioning regimen. The dosage of TBI, the busulfan, the melphalan, like by different conditioning, different groups, this is how they define the myeloablation as considered as defined just now. Next slide, please. How do we define non-myeloablative conditioning regimen? So that simply means the reverse of myeloablative regimen. That means we are saying for myeloablation that the stem cells or the bone marrow aplasia will never recover unless and until stem cell infusion is done. In this case, the bone marrow, after giving this non-myeloablative regimen, can still recover even if the stem cell infusion is not done. So that means in this case, the bone marrow aplasia is temporary and it's not a permanent feature, unlike like a myeloablative conditioning regimen. And because of that reason only, because of non-incomplete sort of myeloablation in non-myeloablative regimens, there can be a component of mixed chimerism that can be often absorbed in these patients. So these regimens are quite often sort of incorporated for either benign conditions or those leukemias, lymphomas, where the sort of disease has been not so aggressive. Next slide, please. So this is how we define sort of non-myeloablative, the dose of TBI and incorporation of fludarabine. So fludarabine is a regimen that has sort of like after the discovery of fludarabine, and after that it came into the clinical practice, only then the RIC regimens came into practice, and those definitions came up after the introduction of fludarabine to the clinical context. Next slide, please. So this is about the RIC regimen, the intensity of regimen. That means that lies between sort of myeloablative and non-myeloablative is what is called as reduced intensity conditioning regimen. And this is how we define sort of RIC regimen. That means intermediate in intensity between the myeloablation and non-myeloablation. So a couple of slides down to the sort of definition criteria. Yeah, this one. So this is how we define sort of RIC regimen in terms of dosage intensity of different regimens, be it TBI or the myeloablative sort of myeloablative drugs, including busulfan, melphalan, or even triosulfan and thiotepa. Next slide, please. So there has always been a controversy around whether RIC is beneficial, myeloablative or non-myeloablative, but I think there is no answer to that. So as we discussed in the beginning, the most important and the crucial factor always is what you can give to your patient, depending on a multitude of factors. That includes what are the comorbidities, what is the disease status at the time of transplant, how aggressive the disease has been, how frail or fit the patient is. So all these factors do play. What is the organ compromise that is there at the time of infections, whether the patient has got some infections maybe small or big at the time of transplant. So all these factors come into play while we are taking a call in deciding which conditioning regimen is better for a patient. Next slide. Yeah, this one. So this is just the definition, like in terms of pictorial description. The next slide, please, of where and how the intensity wise these conditioning regimens can be placed. Next slide, please. This, I think, data can be skipped and we can go to a couple of slides more. Yeah, this one. So which one is better? I think that's what we were discussing. There is no one choice better. Next slide. There is no better option that, okay, this is better, this is bad, this is not good, this is not bad. The most important slide is this, I would say. And this is the take home message, I think, that we should all sort of be fed in our all transplant physicians' minds, that what we have to balance out is the relapse versus TRM. So TRM will increase if the intensity of the regimen is increasing, while if we are not decreasing the intensity of regimen, the relapse rates will sort of scale up. So this is the sort of balance that a transplant physician always tries to achieve in his mind before taking a call, yet that yes, this is the conditioning regimen that I'm going to use for this particular patient. Next slide, please. This, I think we have already discussed that TRM. Yeah, so we can just skip this, not an issue. Couple of slides down. How do we select appropriate conditioning? Yeah, this one. So how do we select a like appropriate regimen? Next slide. So this is what we were discussing, depending on the disease and the status of the disease, prior therapy, depletion and graft manipulation has been done or not. And of course, yes, this is an important point, that what is the experience of the center and the transplant team of using a particular regimen. So I am using maybe flu trio for last 5 years. I will not like to change unless and until I am facing problems with that regimen. And of course, if a center is using maybe Bucai, more myeloablative regimen, they'll be more comfortable using Bucai than shifting to a flu trio based regimen for a myeloid leukemia or maybe other type of leukemias. Then this is the important thing, that experience of the transplant center, how good or bad it is. Next slide, please. Aplastic anemia is like, I think, like I'll not go into the details of the data for like coming to the conclusion and consensus that these are the regimens of choice. But yes, conventionally what we use is flu-cy with or without ATG for an aplastic anemia patient. If he's sort of undergoing a transplant, is planning for a transplant. ATG is more sort of conventionally used. Rapid ATG at the dose of that may be variable thing. If you are using a mud transplant, it goes up to 6 milligrams per kg. But if you are using maybe a matched sibling donor transplant, in that case, you can go up to 3.75 to 4.5 milligrams per kg of rapid ATG. And the other important thing is, like rapid ATG, when to use in a patient of matched sibling transplant, that has been a much debated thing. But of course, those, like people say that if the patient has received more than 23 blood transfusions, he has been adequately alloimmunized to give rapid ATG to prevent graft rejection. Next slide, please. Acute lymphoblastic leukemia. If we talk, the conventional regimen has again been cyclophosphamide TBI, 12 to 14 grays of TBI with a cranial boost if there is a involvement of CNS at some point of the treatment during the some time of treatment journey of that patient. So cranial boost may be added, but the conventional dosages for TBI has been 12 to 14 and cyclophosphamide is 60 milligrams into 2 doses. And that is the conventional regimen. Slowly and steadily, as we were discussing about the limitations of availability of the TBI, so slowly and slowly people are saying that, okay, busulfans can be incorporated instead of TBI. Fludarabine can be incorporated along with triosulfan, or maybe busulfan, flubu or flutrio based regimens are again an option that can be considered for patients with sort of acute lymphoblastic leukemia. Next slide, please. Again, next slide. Yeah, acute myeloid leukemia. The regimen that we have been using now quite comfortably is flutrio at 14 grams per day of sort of triosulfan for a total of 3 to 4 days. That's a regimen that we are using with fludarabine of 30 milligram per meter square for 5 days. So a total of 120 to 180 dose. Usually we try to cap fludarabine around 150 milligram per meter square of fludarabine, a total dose. So that regimen has shown some good results. Of course, there is some sort of concern of slightly increased risk of sort of relapses. But I think still flutrio has been sort of quite good a regimen as compared to the conventional myeloablative, the Bucai, the Flumel, the sort of Flu-Bu. As compared to those regimens, we are seeing quite less toxicities with flutrio, and we are quite happy using these regimens. Next slide, please. Next slide. Yeah, so for myeloma, I think most of us are using Melphalan 200 only and only if like the dose of Melphalan can be reduced if there is some concerns regarding deranged creatinine, elderly age, or any such factor because of which you cannot give sort of myeloma 200, Melphalan 200, then in that case, it can be sort of reduced to up to 140 milligrams. It is said that in patients who are on chronic hemodialysis, we have recently done 2 patients of myeloma on chronic, like regular hemodialysis, and those patients we give 140. Although the data says the lowest possible dose to be given in patients with myeloma on regular hemodialysis is up to 110 milligram per meter square of melphalan can be administered. So yes, there have been regimens that have been tried to be compared, sort of in the backdrop of conventional melphalan, including Bumel, Bortezomib-mel, and other such regimens. But I think just like Archop has stood the test of time, melphalan in myeloma autologous transplant has just stood the test of time. That yes, it has proven to be the most effective and sort of non-toxic regimen to be used in patients with myeloma planning to be undergoing a sort of autologous bone marrow transplant. Next slide, please. Thalassemia, of course, Bucy with or without ATG. If the patient has received significant amount of transfusions, ATG should be considered and added at the similar doses that we discussed for aplastic anemia. Of course, in the background of busulfan with cyclophosphamide, that is the regimen of choice for for thalassemia. Of course, in patients who are a bit elderly, as in like more than 7 to 8 years of age, or who have got significant comorbidities, there is slow and steady trend to use fludarabine, triosulfan, and thiotepa that we are using in a couple of patients. And that is also again showing good sort of responses, including in patients with haploidentical transplant, planned for haploidentical transplant. Next slide, please. Next slide. Yeah, so lymphoma, I think again, the test of time proven conditioning regimen have been the BEAM protocol. BCNU availability off and on becomes an issue. So at that time, we try to replace BCNU with lomustine. Carmustine we try to replace at times with lomustine if that is available, or sometimes even with LACE regimen, the cytarabine based regimen that we sometimes try to switch to. LACE is a regimen that is associated with a lot of sort of gut toxicities, so we try to avoid that. But that is like the switch from BEAM to something else takes place only and only when the BCNU is not available. The other regimen that was sort of shown to have a good efficacy recently in a sort of not randomized trial, but a data was published of a small cohort of patients, was single agent melphalan. So that avoids the sort of requirement of a cryopreservation that is otherwise required while using a BEAM protocol. So yes, so this is about the conditioning regimens that are available. Next slide, please. Next slide. Yeah, so this is just a cartoon that shows that the patients who are undergoing bone marrow transplant, it's not that the journey ends at maybe when they're getting discharged. We as sort of transplant physicians need to percolate to the community and to the patients and to the doctors, our community doctors, that the transplant does not end at discharge. The transplant ends at maybe 3 months or 6 months post-transplant when the patient has got sort of complete recovery from all the side effects that are expected post-transplant. So that is what is the most important thing that needs to be done. This is just showing that patient who develops a chronic GVHD, we all have seen in clinical practice, chronic GVHD patients, like they keep suffering, keep lingering on for months. Ultimately, they sometimes die of bad infections because of the complications of GVHD, maybe Jacob-induced infections or whatever. So these are the problems that the patient and the treating team should be counseled before taking for a patient, any patient for an allogeneic transplant. Next slide, please. So yes, this is the last slide. Conditioning regimens can be classified as myeloablative, non-myeloablative, or a RIC regimen based on the sort of definitions that we just described. There have been the pluses and the minuses associated with different intensity of regimens, of course, that we discussed. Yes, and I think we can come to an end and hand back to the organizers, or if there are any questions, we can take up here.
Thank you, sir. It's a wonderful presentation. You have discussed this very beautifully. But conditioning regimen is something we start thinking when we start planning for the transplant. And I know I have called you many times for the plans and all those things. So you are always a role model. I think if
We are
anybody else,
colleagues, Dr. Ankur. Please don't say that.
sir, please.
We are colleagues and contemporaries.
Thank you, sir. If
Okay.
anybody has any questions, so can be taken. Otherwise, we can plan. We can switch to the next session. Thank you, sir.
Okay. Thank you so much, Dr. Ankur. Thank you so much for giving me the opportunity. Thank you so much.
So we are going for the next session. So next session is role of transplant in relapsed lymphoma. So this session will be taken by Dr. Ketan Madak. He is the consultant hematologist and the BMT physician at National Cancer Institute, Nagpur.
Hi, good evening.
Good evening, Dr. Ketan.
Am I audible, Dr. Ankur?
Yes, you are.
Yeah, so thank you so much for giving the opportunity to give the talk on the role of transplant in lymphomas. We just now listened to amazing talk by Dr. Meet sir on conditioning regimen. we'll carry it forward and try to do the justice. Thank you, Zydus, for helping me out. So can we have the slides, please? Yeah. Yeah, so role of transplant in relapse lymphomas. So, so I wanted to start with this slide because this is the landmark paper which was published in NEGM, which had compared CHOP with many other regimens where CHOP stood out and was found to be best available therapy in the non-Hodgkin's lymphoma. Similar to that, we had papers for ABVD in Hodgkin's and BR in low-grade indolent B-cell lymphomas. So next slide, please. Yeah. So that was quite a few decades back, and in last few decades, what we have got is lot of molecules which could be targeted, which can be targeted, and there have been a lot of newer therapeutic interventions, as you can see in this cartoon. So next slide, please. So coming to a basic flowchart, in lymphoma, there is Hodgkin's. So traditional treatment, frontline treatment has been ABVD, BV-AVD. And for non-Hodgkin's, it has been CHOP plus minus R versus BR in low-grade B-cell lymphomas. But now we have got a lot of many other molecules. Few of them are coming in frontlines. Can you next slide, please? Yeah. So there have been many other molecules which have come up. Many of them are now coming in front line, and there have been CAR T-cell therapies. There have been bispecific antibodies. All of them are going to give competition to transplant in lymphomas. So where does the role of transplant in lymphoma happens? Yeah. Next slide, please. Yes. Next slide. So this is just a ISBMTR data compiled from 1983 to 2021 and was published or was presented at Hematocon in 2022. And it's just to know that how many lymphoma transplants are being taking place in our country. And it's somewhere around 1 in every 8 transplant being done is of a lymphoma patient, either a Hodgkin's lymphoma or mature B-cell lymphoma. So we'll start with Hodgkin's lymphoma. Next slide. Yeah, next slide. Yes. So a role of so autologous and allogenic transplant in cases of Hodgkin's lymphoma. This was one of the study. This was a Canadian perspective which they had published in a transplantation and cellular therapy, and they had 106 patients, of which majority were autologous. And what they showed was that the 5-year PFS and OS was comparable to whatever data we had. Even the GVHD acute as well as chronic rate was comparable to the data which was with us. And this again just reinstated the fact that transplant is still a modality in relapse Hodgkin's lymphoma. Next slide, please. There was always a question initially whether tandem transplant plays any role in relapse Hodgkin's lymphoma. There have been few trials. One of it was H96 trial, which had enrolled to 45 relapse refractory high-risk patients of Hodgkin's lymphoma. And what they found out was that in their study, the 5-year OS rate after doing tandem transplant, autologous transplant, was 46%, which was slightly better than what was reported in literature. So yes, next slide. Tandem transplants remains an option in high-risk patients, but there has been not many prospective studies. Next slide. Yes. So coming to the role of allo transplant in Hodgkin's lymphoma, yes, they are being done now, and actually in increasing number nowadays, because there have been patients with early relapse, or there have been chemo-resistant diseases in whom allogenic transplants are being preferred, especially haploidentical transplants in Hodgkin's lymphoma. And with reconditioning now, there is a less toxicity and less non-relapse mortality too, with better outcomes. Thus, allogenic as well as autologous stem cell transplant still play an important role in Hodgkin's lymphoma. Next slide. Coming to there is always been one query whether immune checkpoint inhibitors prior to allogenic stem cell transplant will lead to any excessive GVHD post transplant, and few studies have shown this, but there was
recent study which had, next slide, please, which had enrolled all the transplant patients who were previously treated with PD-1 inhibitor. And what they found out was that in all the patients, as well as the Hodgkin's lymphoma subset, the grade 3 and 4 GVHD rates was quite comparable, as well as the NRM, the OS, and PFS was quite comparable to the literature. So there have been contrasting studies, and it has been commonly used. Even we have used in few patients in the past, and I don't think so GVHD rates have been on higher side. Next slide, please. Yes, so just in Hodgkin's lymphoma, autologous stem cell transplant still plays an important role, especially in the first relapse, which is chemosensitive relapse. And allogenic stem cell transplant, I would say, would play important role if it's a chemo-resistant disease, or if it's a high-risk relapse, or if it's a second relapse and IIT. Coming to relapsed aggressive B-cell lymphomas, the most common is DLBCL. So in the relapsed DLBCL, the historical management has been to salvage it with the chemotherapy followed by autologous stem cell transplant. But many times the patient may not be salvageable, or the disease may be refractory, and then we may need to go to other lines of therapy. Nowadays, we have CAR T cell therapy, immunochemotherapies, polatuzumab has come up. And of course, allogenic stem cell transplant has always been an option. Next slide. So autologous stem cell transplant has a very nicely established in DLBCL, especially in the relapsed DLBCL who have chemosensitive disease. And this is one paper which was published in the 1995 in NEGM, which had shown that EFS and PFS with ASCT and without ASCT, there is a quite significant difference. Also, is there any difference based on the timing of relapse? So yes, if the relapse is late, the PFS is much better as compared to early relapse. Next slide. Another query which we have always is PET CT scan in PR an indication to do autologous stem cell transplant? So it's not like we can't do it. It can be done, but the outcomes are not as good as when the PET is in CR, but definitely it can be done. There are few CA-BMTR data has been published which had stated that 5-year PFS is around 40%. So next slide is the next slide. Yeah. So is a CAR therapy better or autologous stem cell transplant in these patients who are in partial remission? So this has also been published in the Blood 2 years back, and it had shown that autologous stem cell transplant in this patient did much better as compared to CAR T cell therapy. Next slide. So there was more NRM, more relapse with CAR T cell therapy, but the PFS and OS was much better with autologous stem cell transplant. Coming to allogenic stem cell transplant, it has also been studied as compared versus the CAR T cell therapy, especially in those patients who have failed 2 lines of systemic therapy. And what they have found is that the OS is in fact better with CAR T cell therapy as compared to allogenic stem cell transplant. But yes, there have not been many studies and the numbers have been very less. So it still can't be concluded. There are few patients which eventually would go to allogenic stem cell transplant, especially young patients, high-risk patients, early relapse patients. Next slide. And yes, allogenic stem cell transplant, again, the RIC has done better than the MAC, as discussed earlier. Yes, next slide. So another couple of lymphomas where transplant does play a role is, one is mantle cell, another is follicular cell lymphoma. So mantle cell lymphoma, especially in the advanced stage diseases, if the candidate is a proper candidate for transplant, then yes, we should give aggressive regimens and do the transplant. But this is for upfront this thing. In the relapse setting, definitely, if the disease is chemosensitive, the transplant should be done in those patients. If the patient is young, again, allogenic stem cell transplant has a role in mantle cell lymphoma too. Next slide, please. This is just a paper I wanted to quote here. This was published in the ASH 2022. And what they had, what they wanted to compare indirectly was a cytarabine containing induction followed by transplant versus bendamustine rituximab. Though these are separate studies, what they have shown is that the OS is somewhere around 10 to 13 years. Plus the quality of life considerations and the toxicities are different in both of them. So again, next slide. The transplant option should always be weighed. Upfront ASCT, I would say it's the standard of care in younger patients with superior PFS and duration of response. But otherwise, many patients, they end up getting bendamustine rituximab or some other therapy, and they do quite well. Mantle cell lymphoma, yes. Can you take the slide back? Yeah, so ASCT can be used in CR2 in mantle cell lymphoma. Yes. Coming to follicular lymphoma, again, there is no role in upfront, but in the relapse setting, especially if it is POD 24, that is before 24 months of completing the treatment, stem cell transplant is an option. And also in those follicular lymphomas who have transformed to aggressive B cell lymphomas. Next slide. So there is one paper where basically this is in the upfront setting where they had found out that autologous stem cell transplant versus no autologous stem cell transplant, and they did a subgroup analysis which showed that the patient who had early treatment failure receiving transplant, they had better OS survival than those who didn't undergo transplant. Next slide. So this is another good slide which states that if there is early progressing follicular lymphoma, the role of autologous stem cell transplant as compared to no transplant, the patients who undergo transplant, they do well. Next slide. Coming to the last topic, that is T cell lymphoma. So T cell lymphoma, again, there is established role of autologous as well as allogenic stem cell transplant. These are a couple of studies which I have mentioned here where the PTCL patients who had undergone the autologous stem cell transplant, they did better as compared to those who didn't. And even the role of allogenic stem cell transplant has been established in cases of PTCL patients, especially in the young patients, even in the newly diagnosed setting. So we'll just at the end go through the EBM guidelines as published in 2022. Next slide. And what it states. Yeah, so autologous stem cell transplant, it has a role in especially in the relapsed large B cell lymphoma, that is a first relapse, and mantle cell lymphoma. I would say again the first relapse, though they have said CR1, but first relapse would be the thing. And in the relapsed follicular lymphoma, relapse Waldenstrom's, it's an optional thing. Whereas allogenic stem cell transplant in these lymphomas, it's generally considered later or in the refractory or very chemo-resistant diseases. Similarly, in PTCL, autologous stem cell transplant, they have stated as optional. And in fact, they have mentioned allogenic stem cell transplant as standard of care. And in Hodgkin's lymphoma, as we already discussed, if it's a chemosensitive relapse, it's autologous stem cell transplant. Whereas if it's a chemo-resistant relapse or refractory disease, then allogenic stem cell transplant should be carried. So I will end with this. Thank you so much for giving the opportunity.
Thank you, Dr. Ketan.
Yeah.
One presentation, precise and clear. So in a short time, you have discussed many things. So the topic was quite huge.
Thank you, Dr. Guru.
Thank you. So thank you all my colleagues and the friends for sparing the time for the today's discussion. So as we all know that we have discussed today updates in myeloma. Thank you, Dr. Imran, to discuss regarding daratumumab as first line in the multiple myeloma, the response rates. Then followed by we discussed polatuzumab in Hodgkin's lymphoma by Dr. Mukesh. They have clearly have shown that which are the patients where we can use the polatuzumab as first line, like in ABC type or the high grade DLBCLs, where the PFS is more important in the older patients, and then followed by the conditioning regimen. And at the end, we discussed the role of bone marrow transplant in lymphomas, in the various lymphomas, either in the relapse setting or as a first line by Dr. Ketan Modak. So at the end, I would like to thank all my partners and all my academic partners, which helped me to for the successful of this meeting, and the team, the technical team, and the whole team of the Horizon, which has helped me out to plan the meeting and make this meeting successful. And at the end, the delegates who have made this meeting successful and fruitful for all of them. Thank you, everybody, and good night.
Thank you, sir. Good night.
Technical team,